So let's look at what the consequences of an expanding haematoma are, and what happens if intracranial pressure is going to rise too much. So basically, why are we trying to prevent a rise in intracranial pressure? Well, we end up with herniation syndromes. Okay, let's have a look at this image over here on your right first of all. What you see here is an image showing the dural reflections. Okay, these are folds of dura with the dural sinuses within. I want to draw your attention not to the dural sinuses but to the dural folds. So here we have the falx cerebri running anterior to posterior. Okay, and sloping here over the top of the cerebellum we have the tentorium cerebelli, sloping this side and sloping that side. Okay, so this is tough, non-distensible connective tissue. Its name, dura, from Latin, means tough, durable, and the brain is a relatively soft tissue, so if pressure rises, this is not going to give, the brain is going to give, unfortunately. So let's have a look at what these different numbers mean. Number one is uncle herniation. Always got a bit confused first of all here in uncle herniation. It's nothing to do with relatives, as auntie or uncle. It's this here is the temporal lobe of the brain, okay, and this part on the medial side is known as the uncus, okay, the uncus of the temporal lobe. Okay, so if the uncus herniates due to pressure, it's known as uncle herniation. Okay, so number one, uncle herniation. Number two, central herniation, where the brain is forced down centrally. Number three, cingulate or subfalcine herniation. Remember that the falx cerebri is located here. Okay, that's not going to give, but the brain is soft tissue, that will give. So sub under falcine underneath the falx cerebri. Okay, number four, transclavarial herniation. Okay, this is a particularly nasty type of herniation where the brain herniates through, trans meaning through, clavarial meaning the clavaria, the skull cap, the skull bones. This happens in an open fracture of the skull. Okay, so transclavarial. Number five, upward herniation, and number six, tonsillar herniation, where the cerebellar tonsils are forced downwards through the foramen magnum. This leads to coning. Okay, so in this video presentation we've looked at some basic anatomy. We looked at the different layers of the meninges and how that blood can collect above and below certain structures, giving rise to extradural, subdural haematomas and subarachnoid hemorrhages. We looked at how these present, what they look like on CT, who gets them, what the risk factors are, and how they're managed. We looked at the management of head injury. We thought about that important equation, CPP equals MAP minus ICP, that's the cerebral perfusion pressure, is equal to the mean arterial pressure minus the intracranial pressure, and we thought about ways that we can tweak that equation. We looked at the Glasgow coma scale briefly. We looked at ways that we looked at how we can measure the motor scoring in particular. We looked at signs of a bad head injury, all of which require a CT head if you see them in a patient, according to NICE guidelines for head injury in adults. We briefly looked at what happens if the intracranial pressure rises too high at herniation syndromes, and now we're going to summarize. So what we're going to do is to construct a table. If you're able to fill this table in, you have understood and remembered the main points about these three types of bleeds. So let's go to this table now.